To all my new grads out there, if you are graduating in December to January, congratulations. I just want to say a special congrats to you. It is no easy feat to be graduating from nursing school. I myself was a new grad in December of 2000. Yes, that was 22 years ago, so it's kind of coming up on my anniversary for my graduation, and it's a time I will never forget. I'm sure you will never forget it either. This is a very special time. This is a time when all of your hard work and all of your studies and accomplishments are coming to a close, and you are graduating to become registered nurses. I know it's a scary time to be coming into this field right now. I know it was a scary time when I came into it, but right now in particular, there is a definite temperature of the environment in hospitals, which feels a little warm or hot in some locations, depending on where you're at. But I am here to talk to you about being a new grad, what happens next, what do you do, what do you focus on, what can you not focus on, and how to transition into being a nurse and working in a hospital. Some of you may not go to a hospital. You may end up going to a clinic somewhere. There may be different fields that you want to go into, and we can get into that too. But there are a lot of specialties that you might want to seek out. But right now, what you want to really be doing is getting prepared. Getting prepared to interview, getting prepared to put your resumes out there. And even if your resume seems like it has nothing in it, please don't be worried. You can formulate a what we call a functional resume based on any experiences you've had, including your clinical time, to focus on what your studies are, your accomplishments. You can definitely get hints and tips on websites about how to do a functional resume, and I may even do a video on that. If you put it in the comments that you'd like to see what a functional resume is, I'd be happy to show you. So let's get into this part. You are going into a hospital, or you would like to go into a hospital. What do? There may be job fairs that you attend. There may be some recruiters that come around. I'd like you to try to steer clear of recruiters. Unless they're directly related with a hospital near you that you want to work for, just realize that sometimes these recruiters are just trying to build profiles that they can use for later and may not really be able to place you right now as a new grad. One of the things that works best is getting in with a facility that has a new grad program that is willing to train you. And with that comes new grad contracts. I know I signed one back in 2000 when I went to work for a very large academic hospital that had a residency program. It was a teaching hospital. It was a very intensive ICU situation that I went into, a surgical ICU and cardiothoracic. It was a very intense place to go, but I kind of wanted to start at the top and get my experience and get my seasoning and my feet wet in a place where I knew I would learn a lot, and I did. I signed a contract that said I would work, I think it was 2 to 3 years, and it said if I didn't finish that contract, I would have to pay it back. But what I have found out through other research is those contracts are not always legally binding and that you have to pay them back. Get your experience. Definitely try to stay as long as you can. If there's something that affects your license or it's just a really bad fit, obviously you don't want to stay. You have some wiggle room in those contracts, but I don't want to discourage you from fulfilling what you said you would do. If you signed a contract, do your time, do your 2 years wherever you're getting your most experience, be appreciative of it, and move forward after that if you want to. And some of you may even want to stay. So if you want to stay, that's great. I know 1 or 2 nurses in my new grad program stayed on. I was working very far from home at a big university hospital, and my commute to and from was an hour each way. So in addition to my 12-hour shifts and my 2 children, being a single mom, my days were a minimum of 14 plus hours with traffic back and forth. So I stayed for my time, and then I moved on from there. But we'll get into that later. So what do you do now? How do you study for the NCLEX? How do you prepare for what you're going into with the new grad program? What I would tell you is that if you can get your IP license, which is your interim practitioner, before you take your board exam, do that and start getting to work at the hospital. Getting in there and seeing things happen, starting to understand physical assessments and getting trained on what you're actually going to be tested on is going to be really important, especially coming up as NCLEX 2023 kicks off. In April of 2023, the NCLEX is going to change to a new program called Next Gen. It's going to be similar in some ways, and some people have already seen the tests play out in their current testing. It's not going to be a complete changeover of testing. It's been a gradual rollout of these questions being sprinkled in to see how they work with the new grads. So they are more like drop down menus and prioritization type of skills. And I'm hoping that these kind of the NCLEX will help prepare nurses more. I don't expect that it will prepare you all the way because you get that kind of stuff on the job. But don't overthink your brain. You're going to want to study everything under the sun. What I can tell you is don't get caught up on the stuff that's really like you've got a main focus here, like say something like labs. You don't try to memorize every lab value there is. Stick to the basics. What they're going to be looking for on the board exam is labs that indicate bleeding and labs that indicate oxygenation. Kind of the ABC kind of labs. There might be a couple others sprinkled in there, but for the most part, they want to know that you know what a white blood cell count is. If it's elevated, it's an infection. They want you to know that if the PTT is off or they have low platelets, that they're at a risk for hemorrhage. They want you to just know the basic CBC and chemistry and maybe some cardiac enzymes. I don't know that they'll go that far in it. As far as blood gases, know what the basic range is and why it does what it does. And just remember, everything is a teeter effect. Like if one goes up, one goes down. You'll know this when you look at your blood gases in your book. But don't over make yourself crazy. As long as you know the basic numbers and which direction they're going, you can kind of get the rest of the information off of the patient scenario that they're giving you. So like I said, don't go try to memorize every single lab value. And I would say that even at the hospital, when you go in as a new grad and you are starting to do patient care with your preceptor, those lab values, when they come back from the lab, they're going to have the ranges on them and what's out of range. And at that time, you can speak to your preceptor and discuss what that means. You're learning for that, and what that all means is going to happen on the job. I'm sure you've heard it a million times that nursing school is basically how teaches you not how to kill people. And that's not all the way true. There's some theory in there that I really appreciate. I know for me, at my school, we had a big model that we went on, which was the Callista Roy model. It was taking the person as the trifecta, the mind, body, and the soul, and understanding how that all works together to make up what their diagnosis is and how to treat them. So I learned a lot about that, and that meant a lot to me, and it kind of influenced my practice moving forward. But everybody has their way of doing things, and each school is very unique in what their strengths are in teaching their students. Recently, I pulled up the NCLEX pass rates on the Board of Registered Nursing. This is the California BRN website and all the schools and what the pass rates look like. I was really surprised to see that some schools had a very high pass rate consistently the last 3 years, and some did not, and some had a bump up in 1 year and went down in another. Sometimes this is when they have certain study programs like Kaplan that they have paid to come in and teach you how to test. Some schools do that, some schools do not. My school did not do that. When we got to the end, we were given several options to pay a lot of money to go to a prep course, but I chose not to do that, and I found that just doing the questions that were in like the cards that I bought and reviewing some information in one of the books, the 2 books and the cards, those were my golden ticket, because the cards laid out the questions exactly as they were going to be laid out on the NCLEX exam. It gave the whole scenario, the answers, the rationale, why each one was right and why each one was wrong. And I did several cards a day until I got through the deck of 1,500 cards, and then I went through them again. So I kept going through them. I think I did the card set a total of 3 times, going through the entire set, and I really felt prepared by the time I was done with that. I had also taken ACLS, BLS, and PALS. I got some really good information out of that, and I'm telling you right now, and I will say it over and over and over again, I do not care where you are going. I don't care if you're going to the skilled nursing facility or an ER or ICU. Take that ACLS ASAP. Get on it right now. Don't even wait till you get into where you're going or if you have to have it or not. ACLS is very important in learning the basics to help you reduce code anxiety. If a patient codes, you want to have the basics down and feel confident in your ability to at least have the knowledge base. Because even in a code, you don't have to do everything. If you're a student, go in there, or a new grad, get in there. You can do compressions, or you can get flushes and do the glucometer. You can do the charting and make sure that you're the documenter if that's what you want to be. Sometimes it's really good to be an observer in those situations for the first few codes that you do, because those situations will help you to learn about how the process works. There's always something you can do, and it doesn't have to be the most intense thing in the moment. But it's important when you're in there to try to step back from the brain that's freaking out and just listen to what's happening in the room and remembering what you heard in ACLS and how that is playing out right then and there. So be helpful, don't get in the way, do a part, even if it's a small part, and try to be in every code. Go into the room on any one that you can help with and assist, because you will learn a lot every time you go through it, and as you have more experience with it, you will feel less and less anxious as time goes along. So take ACLS. Get a good study module that you can work on for the NCLEX exam. I have been working on one myself. I'm trying to finish it quickly. I'm getting there. I've got a bank of about 1,300 questions so far that I have been writing in a program, and I really would like to roll it out at no charge to anyone who wants to use it. I'm basing these questions on what the format that the NCSBN has given on their site and how this is going to potentially look. And it's not terribly different than some of the study modules that you're seeing now, but it has a little added sprinkle of something in there. So, I'm working on it and trying to really read into what they're looking for and seeing how I can help any of you students out there be able to access question banks and not have to pay all this money. You've paid enough money for school. And if there's nurses like myself that can help you, I definitely want to do that. If you have questions for me or you're having trouble studying, please feel free to message me. I am available. Look, this isn't my full-time job doing this on YouTube. I have my full-time job. So I'm trying to get on here and do this regularly. I've been off of YouTube for about 2 to 3 weeks. Had a lot going on with work stuff and transitions and a lot of other stuff in my professional life. So just had a lot going on and holidays and all that. So I stepped back for a minute, but I'm going to keep posting every week, probably a few times a week. And you can email me. My email link is in the, if you go to my main page and click on GrassrootsRN, you'll find that I have an email at grassrootsrn@gmail.com. I make myself available. So if you have questions or things that you'd like to know about, let me know and I'll see how I can help. I really would like to be a resource for new grads. I have a very strong passion in my heart for teaching. I'm not one who doesn't do. I teach and I do. So I have a full-time gig and I'm doing this. But I feel like it's an important relationship because I'm excited about the new nurse coming out, like all of you. I think it's really important that we as nurses at my experience level embrace this. But you're not always going to have nurses like me who are going to be your preceptors or the nurses that you see in the hospital. You might get a nurse ratchet who is really grumpy and not very nice and is looking at you with question and doubt all the time, making you feel bad. I have to tell you, you've got to make sure that you get your emotions in check. Remember that most of the things that happen when people are giving you, snark or they seem like they're not being very nice to you, it really doesn't have anything to do with you. It's them. They don't want to have someone following them. They want to do their own thing. They're not up for teaching because they're grumpy and they don't want to talk through their processes. That's okay. You just need to be able to find and let them know and really look them in the eye and say, I really want to learn from you. What can I do to facilitate this and how can we work together so I can learn? The most important thing is that you have a nurse who is going to allow you to do the tasks without constantly micromanaging every little thing you do. That may happen in the very beginning because you don't have experience with certain things, but once they get more comfortable with you, you really want to have some freedom where they can see what you're doing and critique what you're doing, and a relationship can build on how to better your practice. You have to learn too that the critiquing that is going on isn't personal. It is about trying to help you make your practice better. So I just want you to consider that. Interpersonal skills are critically important. When you are in a hospital, it doesn't take much to understand. I mean, you can go on TikTok right now and look at the fire that's going on over there. There's nurses like screaming their heads off about everything and complaining, and new grads complaining, and everybody's complaining, and patients are complaining. It's kind of a hotbed over there for that. So kind of might we want to stay away from some of that right now, because those kind of conversations aren't always constructive in building a work relationship. What you really need to focus on is being respectful, because for the first time when you get a new job, it's like you're coming into someone else's house. That nurse has been there for 25, 30 years. You're coming into her space and or his space, and you want to make sure that you're respectful of that, and that you give credit to where it's due. You're respectful of your preceptor, and that you can build a relationship where you can learn from one another. If you find that you get a preceptor that it's not working, the personalities aren't jiving, something is wrong, because not everybody has to like everyone else. Make sure that before you jump the boat on that you have a conversation with that preceptor. Be respectful. Be complimentary where you can. Like, give her or him credit where credit is due. And maybe just let them know that the personality type of people that you are isn't a good mix. So there's no harm in saying something like that. But you have to be careful how you say things. I hear people all the time saying, well, someone snaps at me, I just snap back. That gets you nowhere. If someone is snapping at you, you need to stop and think, why are they snapping at me? What did I do? And how can we fix it? Or remediate it and ask them to talk to you in a different tone. Tell them maybe, like, it doesn't work for me to have that kind of, that kind of criticism coming at me that way. I am, I'm definitely a verbal learner and an auditory and visual learner. Like, let them know how you can learn from them. So give it a chance, and give it a good chance before you go asking your manager for a new preceptor. But I will say this, if you have a preceptor that's only been there for a year or two, they don't know how to manage. They're still learning themselves. They have figured out their own practice, but they're not going to have an easy time telling you how to do yours. And it may come off as bullying. So if you kind of feel like you're in a bullying situation, you might want to get that in check. Bullying is bullying to a degree, and it happens all the time. But you didn't get into this business to be bullied or have someone undermining your practice to make mistakes so that you have to clean things up just because they're testing you. That's not okay either, because that can affect patient care. So all that said, we're going to jump into the next part. When you go to your first shifts and you're working in the hospital or wherever you're working, please make sure that you're prepared. Please get there early, not 10 minutes, not at least 15 to 20 minutes before shift starts. Respectfully go over the computer, find out a little bit about your patient. You don't have to go write down everything because you're going to get report. Right before report, a minute or two before you go up to the desk where you're giving a report, go in and say hello to the patient. Say, hello, my name is so-and-so. I'm going to be your nurse today. I am just going to get report, and I will be back shortly to go over everything with you in a few minutes, but I just need some time to get report from the nurse that's going home. They kind of like that. The patients want to know what's going on. They're laying around, they hear all the noise coming and going, but just going in there and letting them know, giving them eye contact and saying, hey, I'm going to be here to care for you. I will be back by this time, and we'll go over your, what's going on with you. A lot of people appreciate the fact that you popped in the door, because things get really busy when you first get to work, and it can often be hard to pop back. They may not have even seen their nurse for the last hour or two. So it's nice that you've walked in and said, hey, I'm here for you, and I'll be back by this time, and kind of give them a time when you're coming back to do your full assessment. Don't wait for MedPass to go back in that room. You need to have assessed that patient before you go do that. An assessment can be done in 5 minutes. You can go in, quickly look at the patient, get a full kind of, you don't have to fix everything right then and there. Get a full idea of what's going on, check them over, check your monitors, make sure the parameters are set, look at their lines. Is anything blown? Anything emergent need to be taken care of? Any bags about to run out if they're on any drips that are sensitive? Just do that quick once over, wrap that up, go on to the next patient. Do the same thing again. You want to use that 10 minutes to do your quick assessment. Go back, make a note on that quick assessment, and then you're going to go back in later and do your, a more full, thorough assessment. But knowing that you've checked the patient, you've checked to make sure monitors are set, that there's no alarms that are silenced that shouldn't be silenced, parameters are set, and everything is running as appropriate, and there's no drug bags about to be run out while you're doing something else. So try to just prioritize. You will find your flow, and that sometimes can take time. Finding your flow in ICU or med surg or wherever it is it takes time to find flow on where, how you're going to get through your assessment and begin your day. So if you can start establishing patterns really early on, and one of those being when you're a new nurse going in and kind of reading a little bit on your patient, getting an idea who they are, what they've been through, read the H&P and the surgical note, that's a really good start, and it really will prepare you as you go about to take your report from the nurse. Let the nurse that is giving a report guide the report, and do not interrupt them during report. That is a big, big pet peeve of a lot of nurses, is that nurses will interrupt them during report before they've gotten to the point where they've given all the information. Let your nurse give you all the information that he or she has. And if you have valid questions, and I'm saying valid questions, if they have not hit on certain things that you have questions on, you can ask those. But don't be sitting there asking about lab values and what the peeps and the pips and on the vent are. You know what? Those are settings, and those are all written down. Those are all on orders, and you can check those off when you go check with the patient. You want to know, has the patient been bucking the vent? Are they sedated enough? Do they need to be sedated more? Is there anything going on with pain control right now that needs to be handled? Are they diabetic? Is there anything major that needs to be handled there? Just handle the big stuff, and don't get all caught up on these what's the K level and what's that. Okay, that stuff you can look at when you sit down after that nurse is gone. Let them give you the important highlights, and if there's other things, don't get into petty stuff. It's not worth it. It seems petty, and your lack of experience shines through when you do that kind of stuff. So anything that can really be looked up in the labs or anything else, which you're going to do anyway, if they haven't read it off to you or there's not an intervention planned for it, don't go into it. These people need to go home. When somebody's done a 12-hour shift, they are ready to go home. They've been there all night or all day, and they need to go. So make sure you get them out of there at an early time, and that respect for you will grow tremendously. When you respect other people's time, it goes a long way. And the same goes with your patients. Let your patients know what is going on. When you're going in to do that assessment, like I said, introduce yourself. I'll be your nurse. I'll be back in 15 minutes, and we'll check you over and tuck you in and do what we got to do. If you have an emergency pop up where a code is going on 3 doors down, every patient in there knows something is going on. You don't have to violate HIPAA, but what helps, if your patient needs some assistance that you can't give right away because you got to go run down to that code, it goes a long way to say to your patient, listen, I have a patient that is in distress and I need to go tend to that patient. You are also important to me, and I promise you I will be back here in just a few minutes, and I need to go give that patient the care that they need right now, that if it were you, I would be doing the same for you. And be nice, and usually they're like, go, do what you got to do. If you don't tell them and they don't where what wonderland you went off to, they're kind of on the call bell wondering, is my nurse ever going to come back? And if you are in a prolonged code situation, there's a lot of people standing around a code. What you can do is point to a person who's on the backgrounds of it and say to them, hey, Amy, I need you to go check in on Mr. So-and-so and make sure that he's okay while I'm in here. Have one of the techs go and do it. That is a direct order during ACLS, and make sure you have a good relationship with Amy, but let Amy know that since you can't leave the code, you're going to ask her to go and check on your patient or check on other patients, because they kind of get left to the wind when that kind of stuff happens. So just have a plan in place, and I think telling your patients and giving them a good idea of time, what to expect, and just communicating with them, it really goes a long way. I do not have patients get angry with me about waiting. That includes some of my wait times in the ER that are insane. I keep in touch with people in triage. I tell them, listen, I know you're going through this right now. I don't have a bed, but as soon as I do, I will bring you in. But we're looking at about this many hours. If I can get you in sooner, I will. I'm not going to leave you here in the lurch. If you need a splint right now to hold that, I'm going to take care of it right here and now. And if there's any preemptive orders that we can get on the cooker in the back, talk to the doctor and see if they want to do anything. There's some of the orders that can be done while they're in triage, and it eliminates a lot of longer wait times. So that's certain hospitals, and that's knowing your doctor, especially in the ER. Typically, I've known my doctors, and if I see a deranged fracture, I can let the doctor know, hey, the ankle bones are definitely not aligned. Probably should go get a 3 view. Check the ankle. What do you think? Oh yeah, he'll order it in the system. Patient can go and come back, be splinted and waiting for the exam. That way X-rays are done once they get to the back. So kind of just like I said, expedite it. If I have patients waiting for hours in triage, I circle back every 2 hours at least. I go back and check on them. If they were having trouble with asthma or something else and I couldn't get them back, I do a SAT, I reassess, and I chart that the patient was reassessed in triage. Anytime you have a wait longer than 2 hours, it is your duty to go back and reassess those patients and make a note. It can be a quick 2-line narrative that you went back and rechecked that patient, and continue to make eye contact with them and let them know that you care. Let them know they haven't been just left there, and that anything you can do, you will do. If they need an ice pack, make sure to get them one. If they need, like I said, splint or something else, get them one. If they need a wheelchair, have someone get one. Try to get them in a position of comfort where they feel like they're getting at least some aid out in the waiting area in triage. Like I said, little goes a long way. You can help people. You can tell them they're not forgotten. You can give them estimated wait times. I promise you, it will make your job and your life a lot easier. So I'm trying to just give you hints here on things that I do that I have found worked. I've seen people blowing up on TikTok, showing people getting really angry in ERs, and there's all this back talk between the nurse and the staff that does not need to happen. There is no need for confrontation. I don't care how crappy that patient is being. I know we say we don't deserve abuse, and no, we do not. But what we have to remember is that people are coming to us in their time of need. And at their time of need, there may be things going on in their life that we don't understand and we don't know about. And we have to try to put ourselves and have some empathy, put ourselves in their position and imagine how they must be feeling. When they come up to you and they're screaming, what you can say to them is, not just, I'm so sorry. You can say to them, I know this has to be incredibly frustrating. I wish there was more I could do. I can't imagine what you must be feeling right now. Is there anything else besides this or waiting that I can do for you to make you more comfortable in the meantime? That may not defuse the situation, but there are ways to de-escalate a really angry patient who's just pissed off about the wait time. You can definitely talk to them. You need to let them know that you care. You need to let them know you're trying. Give them an idea of what you're doing. And just make contact. Don't just leave them sitting in the ER for 10 hours with nobody telling them what's going on. In some situations, these ERs are backing all the way up, and it has nothing to do with the nurses being at fault. It has to do with, problems with administration, not having staff, or if things are bottlenecking for other reasons, or bed control is not working efficiently. It's not all down to the nurses. The nurses are just the ones you see. And this kind of kick the dog thing is happening where they get angry at the first person that they see. So we've got to do better. The patients have got to learn too, and they've got to do better. But I think if we communicate appropriately, we can do our part to try to de-escalate those kind of things and make it so hopefully it doesn't happen. So this is just my little bit of advice on how to handle some of these kind of situations, how to handle your preceptor, your nurse, whoever you're going to have. I hope and pray that you have someone who is like me, who I am really, really excited when I have new grads and new students, because I do like to teach what I'm doing. I have gotten into a pattern where I start talking through things as I do them out loud, because the old adage was see one, do one, teach one. Well, I've done 1,000 of them. So when I'm going through the process of doing, I'll talk about what I'm doing. When I'm putting a tube in, why am I warming it so it gets, it's not so rigid going down? Why am I lubing this end? Why am I measuring this way? I'll kind of like talk it through, and the patients appreciate that too. They want to know how this is going to go, and when they hear you talk through the procedure that you're about to do, it gives them a level of confidence that you know what you're doing. It's important that when you do that and you kind of explain, that they're getting a full picture of what it's going to feel like when that tube goes down their nose. Hey, you're going to gag a little bit. I'm going to help you along by giving you a cup of water. You wouldn't take sips with your chin down, and it will help move that tube into place without pain. So do your part. That's all I'm saying is hope you have a good nurse. I hope you have a good teacher or somebody who's willing to work with you. don't just take the first job that you get. If one of these recruiters comes along and says, oh, we're going to give you a $10,000 sign-on bonus and a blah, 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 and there's really not a big training program and they're just going to throw you into the wolves, be forewarned. There might be a problem here. Whenever you see gigantic sign-on bonuses and writing offers right away and trying to just get people in without you even talking to the department manager, it's just some HR person trying to pull you in with an enticing little carrot. Be careful of that. There's some bad things that have gone on with that I know of and I have experienced, that most of those hospitals don't end up even paying on those contracts. I got into one time where I was offered a $10,000 sign-on bonus at this big hospital. I went and I did my part, and literally the day before my sign-on bonus was about to be paid, they came up with some reason why they couldn't pay it. I was really upset about that, and I eventually left because I knew that they were not going to make good on the contract. They didn't have to. They could just say that they had budgetary constraints and they couldn't afford to pay it. So make sure that there's that wording in those contracts doesn't alleviate their responsibility to pay the contract that they said they were going to do. Take that contract to a lawyer, pay the $200 or $300, and get them on with you so that they can review contracts for you and let you know if they're okay, if they're good contracts or if they're bad contracts. A contract is a contract, and remember that. You have to abide by the contract once you sign it, and you don't want to get into a contract that's a one-sided deal where it's protecting the hospital and it's not protecting you. So just know that. Let's see, what else do I have here? Okay. Certain drugs that you want to know about with the NCLEX exam. Know about insulin. Know about long-acting and short-acting. I think it's for the last 30 years that question has been on there about how to draw up long-acting and short-acting in the same syringe. That you know what question I'm talking about if you're a nurse. Let's see. ABGs we talked about. Know your PaO2 and your PCO2. Know the things that are balance-based that can tell you if the patient is in CHF, over-oxygenated, under-oxygenated, and or those kind of things. Like if they were, a tube was put in, a breathing tube was put in, and they were getting low PO2. And the chest rise and fall was happening, but upon auscultation, you only heard breath sounds on the left side. Well, putting the tube in too far into the right mediastem bronchus means that they inflated one lung and not the other, and it needs to be pulled back an inch. So that's a simple one that comes up a lot on the tests. Learn to prioritize. Learn to prioritize your duties to the patient when you're doing your assessment. When you go in there for the first time and the second time, not the first once over, but the second time you go in there after you've gotten full report, remember, doing a med pass is not the most important thing. The most important thing is checking your patient head to toe. I'm not kidding, head to toe. Neuro, get the neuro, check their, mental state, check everything, check their body, make sure there's no wounds, roll them over once, let them know you're looking at their back, make sure there's no pressure signs. If they're in a bed that needs to be changed because they're starting to get pressure ulcers, make a note of it. Check their IV sites, make sure they're patent, all the way around. If you have to flush and change caps and all of that, make that for a scheduled time when it's between med passes. You don't have to do the whole dressing change and all of that at one time, but you need to make a note that needs to be cleaned and those caps need to be changed on those central lines and a new dressing in place, because that's part of what you need to do that day. If they need a bath, plan it at the time of the night when it's not eating time, it's not med time or something else, when it's a downtime during the night, and you can have a nice peaceful bath for them at 3 a.m. So prioritize, check the patient head to toe. And I mean that head to toe. Do not skip things. I don't want to see WNL over pupils for 3 days when he has a blown pupil. And then what that says to me is we never looked. So writing WNL is not acceptable. You need to write the size of the pupils, were they equal, reactive, and all of that. So document it the way that you saw it, but don't skip things over, okay? If it's a stroke patient, do your neuro assessments. Do not chart what you didn't do. Look the patient over, check your monitors, make sure that your parameters are set. If they have an intracranial pressure line and a CVP line and an ART line and a Swan-Ganz catheter with all the numbers, make sure nobody has silenced those out. You don't want them silenced. You have to have them on. It is very important. Make sure that the parameters are set and it's at a level you can hear it. Now here's a quick hint for you about artifact on a regular EKG, the two lines that come across the top for the cardiac rhythm strip. Sometimes with the vibrations of the bed and all the things going on, or the ventilator, you get a lot of artifact in the EKG line. There is it'll keep binging that they're an atrial fib, but they're really not, and it won't go off. But what you can do is filter the line. You go into the monitor and you put in filter. It will filter out the artifact for you, and that will stop the, unnecessary binging on a falsified atrial fib. So go in and you filter the artifact. You pick that setting, you change that over, and it will clean up the strips. So that's important to do so you're not chasing alarms all night. But having those alarms set appropriately is correct. Zero your lines as soon as you get there. The first assessment when you're checking the patient, go through and measure zero your ART line, measure zero your ICP line, your CVP line. Just check the placements. They're level with where they're supposed to be. Do your zeroing out, do it on the monitor, and start fresh. Because if it hasn't been done, it has to be done every shift anyway. A patient moves around or something happens, you need to re-zero them and go from there. But doing all of that shows that you're being prudent to what you're supposed to be doing when you're checking the patient. It's all part of the assessment. Now, make note of, when you're doing your assessment, if there's lines that need to be changed because it's been 3 days or whatever since the last one, or a dressing change, mark those things down on a special part of your paper. Time when you're going to do all those dressing changes at one time. If there's skin stuff, make sure you document it, take your photos, and do staging. But again, set that up for maybe when you're doing the bath time. When you're doing their bed bath, plan to do their wound staging. And do whatever you can to minimize friction or whatever. And make a note that if it's a new wound, that you want to talk to the doctor about nutrition consult. Because they need to be brought in. When there's a wound, either wound care consult, nutrition. Nutrition is how they get to heal. It's important that their diet changes when they have a wound. They have to have more high protein diet in order for wounds to heal. So the doctors will want to get nutrition involved if wounds are happening or they're not healing properly. Some of the stuff you're going to learn as you go, that if this, then this, if this, then this. And it feels so scattered when you're a brand new nurse. But as time goes on, I guarantee you it's all going to feel like it's stuff you do every day. I know it sounds crazy. I did it too, but I promise you it will get better. It's going to feel overwhelming for the first year. And then it'll start to feel like, okay, I got this. But sometimes you have a lot to do and there's a lot on your plate. And especially as a new grad, it's a very scary time. And I just want to impart to you, I've said so many times in other videos, as new grads need to speak up. You need to know when to speak up to management. Said all of that, but I also realized that as a new grad, it's hard to speak up sometimes. It can be hard because you're new. You haven't built your skills up yet, and you don't feel like you have the voice. And I think that sometimes administrators take advantage of that. They take advantage of it by piling on work, knowing that you're not going to speak up. But if you're in the state of California, you know your Title 22, and if you don't, you better go print that out. You keep that in a folder somewhere, because if you do not understand the words of Title 22, you need to. That is the law. Title 22 tells you how many patients you can have, how many patients you cannot have. And if you are taking more than what you're supposed to have per Title 22, you're working in dangerous territory. And the hospital may not get in trouble for assigning you. You may get in trouble for accepting that load. If someone wants to assign you 3 ICU patients, you better understand that you have the right to, assignment despite objection. But if something happens to your license, it's on you. You have the right to refuse. And the law states you have the right to refuse without being penalized. So by understanding Title 22 and reading that, I think you will get a better grasp for what your rights are in California. Can't say anywhere else. And Massachusetts has theirs too, but Massachusetts is a little less defined. So, but know what your Title 22 is. And if you don't have Title 22 in your state, I am begging you, don't just sit on TikTok and complain about it or come on YouTube and complain about it. You need to read about it. Pull the one from California. It has been proven to reduce patient mortality, reduce patient stays, improve their healing, and improve their courses of stay, less falls. And money-wise, that's important. There's less nosocomial infections. There's so many reasons on why patient ratios matter. And if you don't have patient ratios in your state, I hope that you are trying to help get them done. Currently, there are two bills. There is a House bill and a Senate bill that are both ratio related to imply federal nursing ratios onto the current system as a whole. So it wouldn't be state to state, but this could take a very long time to pass. And I haven't read both bills to the degree I'd like to. The HSB, the House bill, seems to have been, they both got put through at the same time. So I'm going to put a link down below for the Senate bill and the House bill that are currently in introduction phase. Neither one are going to be passed yet, but they've been introduced to the House and the Senate, which is very important because it takes an act of Congress to get those approved. Could be a year or two before they actually make it to what they need to do. But my point is, I'm going to put the links down below. I want you to read them yourselves, and if you feel passionately about those ratio laws, this is where you use your power, the power of your pen, the power of your voice, or the power of your email to let your legislators know that you support this. So we can't just sit and complain about it. We actually have to do something. There are things being done, and it's important to support those bills once they come about because they can help you in your state. You can also write to your local congressmen, your governors, and let them know how you feel about it. Don't wait for the American Nursing Association to do it for you. You write. You take your power, you put it out there, and you let what you feel be known. So it's hard to do in the hospital when you're a new grad. It's hard to go to management and say anything. But honestly, I will say this. If you are being truly bullied and you are being berated and things are happening that shouldn't be happening or someone is sabotaging your practice, you need to go to management. That is critically important because that should not be happening. We have a hard enough job as it is, and we don't need people like that undermining our practice or trying to screw with us as you're trying to learn what you got to learn. So I know it's going to be hard. There is a whole level of politics and things that go on that I wish they did not, but it was very heartbreaking to me as a new nurse to see how things really worked. The disparity in access to health care, who got care, who didn't, who got the best of care, the VIPs and the, la-di-das. It blew my mind when I worked in transplant, some of the things that I saw. I've seen it elsewhere too, where there is a disparity in the level of health care that some people get. That can be really soul-crushing to a new grad, and I understand that. You kind of come out of school with this altruistic, I want to save the world, and a really bright and cheery demeanor of thinking that you can get all this stuff done. But it's hard to get stuff done to help the population when you haven't yet been able to help yourself in getting your skills up to speed and getting yourself known and building some rapport with others. So get as much support as you can. Find healthy channels and forums that promote positive, constructive ways to enact change. Try to stick away from the ranting because the ranting can only fuel negativity. It's important to be progressive in writing your legislators, writing Congress, and writing for those bills to get passed. So you do have more power than you think. Standing up for yourself is important when needed, but I'm also going to caution you about talking back to nurses that seem to be talking smack. There is no reason to be giving lip service to anybody and being defensive. If they are acting a certain way, don't give it back to them that way. Kill them with kindness. Try to get to know why they are the way they are. have a serious discussion. Even if they don't want to, say, hey, we need to sit down and talk about this. We have different communication styles, and I communicate this way, and apparently you communicate this way. Let them know, I want to learn from you. I genuinely want to learn from you. And how can we communicate better? Most of them are going to like step back and be like, all right, okay, so I hear what he's saying, or her, whatever, and I think I need to do something about it. Like, sometimes just being called out on your attitude like changes it real quick because somebody actually noticed. I think some nurses have attitude, they don't even realize they have it. It's come from a place of they're super busy, they're super pissed with their assignment or something else, and they kind of snap at anyone around them. It's like the kicked a dog syndrome. So it doesn't make it right. It does happen. So you want to just work with what you've got, be professional, communicate whatever you can in a positive way. Learning to communicate effectively is critically important when you are a new nurse and you are out in the field interacting with healthcare providers for the first time. So I know people feel like it's like, oh, well, know your place, that kind of stuff. No, yeah, you do need to know your place. You're a guest in someone else's house. And initially you are anyway. And you are being brought in, and that's a special thing. And they want to teach you, and they want to know that you're willing to learn. Nobody wants to deal with a know-it-all nurse that comes out of school knowing everything and, acts like nobody can teach them anything and that they're going to save the world. Good luck with that. If you are one of those people, bye-bye. We won't be working with you too long, because the bottom line is you don't know everything. And you do know a lot, and you may have some information about some stuff that's new way of doing things, new way of technology. The way you approach and communicate that is very important. You don't want to come off like a smartass. That is just like the first thing that any teaching nurse is going to be like, okay, this one's hard to teach. They don't want to learn anything. They know it all. And then you watch them go make a million mistakes because they know it all, or so they thought. So be willing to learn from your nurse preceptor. Put away some of the judgment that because they've been around for 40 years, that they don't have anything to teach you, because obviously they are like Yoda. They have everything to teach you. And if you will just open up your mind, they can offer you the world, I promise. So be open to that. Study your butt off, because when the NCLEX is done, you get that nurse license in hand, you're like, ooh, ooh, ooh. Yeah, that's your bargaining chip. And you're going to protect that with your life, because everybody's going in after nursing licenses right now. So you got to remember, protect it. And the main thing I can tell you is never, ever, ever document something you didn't do. And if there's a problem, like you missed a wound dressing or something else, you need to document in the chart why it got missed and why it's okay to wait till the next dressing. If it's not, go get it done. But the bottom line is, you cannot document on something you did not do. That constitutes fraud. That constitutes falsifying records, and that can get your license suspended. So please do not ever document something you didn't do, even if the hospital presses you to do so. If they're pressing you to document something you didn't do, you need to talk to your ethics committee. There is always an ethics committee at every hospital. If they don't have an ethics committee, then you contact CMS. Let them know that you were asked to force to document something that didn't happen, and there'll be an investigation, because the hospital can't do that to you. Even if they want you to check the box, do this, that is a no-no. You document what you did, and that's it, okay? So keep your documentation tight. And I say that to everybody. Don't step outside the bounds. Don't check boxes you didn't do. And don't within WNL everything. Within normal limits doesn't exist. WNL means we never looked, okay? So if you see that on a chart, that's a no-no. What else can I tell you? IVs, you'll get them down. Practice, practice, practice. You don't have to practice on all your friends. You're going to get practice in the hospital. You do a few of them, and then you finally realize, pop, they're in. Some are harder than others, but it takes practice, and you learn that on the job. Go into a room with confidence. Don't be sweating your brains out. Don't tell them it's your first time unless they ask. And if all goes well, you will hit a good IV right off the bat. You'll learn how to do an IV. It's not that hard. People always worry about that, and it's like, it's not that big of a deal. All right. We went over how to assess. I probably could do a whole video on how to assess, but I'm trying to do it as a blanket whole. It's hard because there's different ways that you have to assess an ICU patient versus an ER patient, which is way different. We have the whole trauma, strip and flip, make sure you do all the things. And that's a specialized area too. So assessments in there, we do focused assessments on the problem at hand. Focused assessments. And if there's a major other problem that's going on physically, yes, we'll address that too. But our primary focus in the ER is what we call a focus assessment about the problem which they arrived for. So there's that. Okay, what else can I tell you? I wished I had known that hospitals and healthcare was so political. And I wished I had known about ratios. We had ratios long before I even knew we had them, and I was getting murdered by patient loads that were just like 10 times what they should have been at times, and that wasn't right either. But, live and learn. And you're going to be doing a lot of that, living and learning as a new grad. So I want this to be a positive, uplifting thing, and I am so proud of you for graduating. I mean, if I could be at everybody's graduation, just go to a bunch of graduations every weekend, I would do it, because every time I see new grads, I'm like, yay, we have some new ones. It's like having new babies. I don't want to call you babies. You are professionals, but I am so, so, so happy to have you, because a lot of people have left the field. I'm like the last of the Mohicans here. I have been doing this for 22 years, and most of my colleagues have left. They've decided, bye-bye. I had a little hiatus there for a while, a little after the pandemic. I worked during the pandemic, and then I had to take some time off. I had a death in my family, and I decided I was going to step back for a minute. But it was just for a minute, and I just, I had to do it. But coming back, it has been a whole different experience, and I know what bugs me so bad is that so many people have left the bedside. So bedside nursing is a passionate thing, and it's a ton of hard work, but I'm passionate about it. So I hope that I can work with some of you all. I can help impart my knowledge. I got a few good years in me left, and I would love to be able to help the next generation of nurses coming along to the practice. So if you have any questions, I would love to hear them. You can either drop them down in the comments area, or you can email me on my site. There is a link in my description. It's grassrootsrn@gmail.com. So I am available that way, but I do want to hear more. I'd like to know what you want to hear about. And I'm just going to keep talking. I know I've been away for a few weeks here. Just had to do some of my own things, but I'm back, and I will be consistently on here, and I want to keep having conversations. Yeah, it's really late right now. I'm getting really tired. I'm on kind of a night shift schedule, so yeah, I decided to do this live at 2-something in the morning. So I'm a little bit tired. Anyway, I can't wait to hear how your journeys are going. And I do want to know. I want to hear where you guys are going out of school. What kind of placement are you looking at? Where are you being placed? That's important. I want to know so I can kind of figure out what the pulse on where new grads are going after graduation. So yeah, keep in touch. Let me know. Please subscribe to my channel. I would really love that. I am going to be producing a ton of videos, and I already have. I had put out 40-something videos in the last 2 months. So I want to hear what you're doing. I'm going to keep coming back and putting more and more videos up. I would love your subscription, and please click the bell notification so that you can get updates on when new videos drop. So we're going to have some exciting things coming forward. Like I said, I am doing a NCLEX 2023 version. Maybe you can help me with that on what you would like to see. And yeah, please keep in touch. Please subscribe. This channel is still a baby channel. I have 25 subscribers. I would love to have 1,000, but I'm just working on it right now. It would really help me a lot. What I do on here is for free, and I want to keep it that way. But it does cost me money to do the live stream services and the lights and the cameras and everything else, and I can do that. So I want to do that for you. But what I need to know is what you want from me, and I want to continue to put out good, high-quality content that you can listen to or you can watch that will help you learn. And hopefully I can help build this question bank that will help you with the NCLEX 2022 and give you some more clarification as to what that's going to be like. So if you want to learn more, please subscribe. please. Ding, ding, ding. And hit the bell notification. And like would always be awesome too. I love that. So I hope you all are having a wonderful holiday. What's left of it. We are coming into the new year. We're screaming on in. But again, finishing out 2022 strong, you new grads. I'm so proud of you. If you're a December grad, I know it's a hard time to graduate, but you know what? Amen. You did it. So give yourself a huge pat on the back, and keep moving. Don't stop. Don't stop. Do not stop. Do not slow down. Don't take a gap year or gap month or whatever. Get in there. You don't want to get laxed, because the minute you do that, it's harder to re-enter. So just get in there and take your vacation later. That's my take. So please do it. And yeah, get your resumes out. If you're having trouble, send me an email. We can go over that, and I will do anything I can to help. So I just want to wish you all a very happy new year. It's amazing. We're already at 2023 in the next couple days. I'm super excited, and I hope you are too, because 2023 is going to be amazing. So I hope you all have a great night, and we'll talk soon. Peace out. So sorry. This end is so weird.